morning, everyone. So today we're going to be critically appraising a systematic review and network meta-analysis. So this is a clinical scenario. A 40-year-old gentleman presents to OPD for management of type 2 diabetes mellitus. He is already on metformin 1 gram twice daily and 10 little bit 20 mg once daily. His glycemic parameters are well controlled. So he has read somewhere that there are newer drugs which actually reduce mortality. He has recently read about semaglutide, liraglutide, all those drugs. The recent news was there. So he wants to know whether should we consider changing the medication. So for that question, to come to an answer, we look at we look through the literature and we find this recent article in Annals of Internal Medicine, which is comparing newer pharmacological treatments in adults with type 2 diabetes mellitus. This is a systematic review and network meta-analysis done by the ACP. So to critically appraise this article, we'll be using the JAMA User Guides Critical Appraisal tool. So there are three main sections in the JAMA User Guides Critical Appraisal tool. So first one is, we are trying to see how serious is the risk of bias. The second set of questions will be for the results, and third set of question will be for how we can apply the results to our patients. So how serious is the risk of bias? We answer basically these four questions, which we will be going into in detail. So for the risk of bias, the first question is, did the meta-analysis include explicit and appropriate eligibility criteria? Yes, they've clearly documented explicit eligibility criteria. They mainly used patients, included all studies with patients with diabetes mellitus. Intervention and comparators will go into detail in the next slide. And these are the main outcomes they looked at, in addition to adverse reactions also. So the interventions mainly were DPP4 inhibitors, SGLT2 inhibitors, insulin, long-acting insulin, GLP-1 agonists. Other drugs also they mentioned, but none of the studies had those. Comparators they've used are also placebo in addition to the other drugs. So the eligibility criteria was broad. They included a large number of studies, which makes our results generalizable. They've included any trials in adults with diabetes with these interventions, and trials which are longer than 52 weeks with more than 500 participants. However, they've used multiple agents in the same class of drugs, and they've also compared multiple doses. So that can cause heterogeneity. So there can be, if you use a lower dose of this drug, that can show that the drug may not be working in some studies. So because of that, there can be differences in outcomes. Other things which they could not control were the other anti-diabetic agents which were used. So other than the study drug, they could not control the standard of care at the local, in the different RCPs. So in the different RCPs taken, it was the standard of care was different. So other anti-diabetic agents used varied in their levels. So that will also cause a significant amount of heterogeneity in the outcomes. So the second question is, was the bias selection and reporting of studies unlikely? So for this, we look at how the studies were taken, the different RCPs were chosen. Like what Sir was saying, we're supposed to go through literature in an exhaustive manner. So all the databases which are there, we're also supposed to look at other language studies. We're also supposed to look at trials and trials registries we are supposed to look at. So they've only looked at the Medline and Embase databases. They've also looked at reference lists of recent systematic reviews in Cochrane and the Agency for Healthcare Research and Quality databases. However, they have not mentioned any registries being used. Other languages were not being used. Experts were not contacted, and unpublished studies also were not contacted. The problem with this is that a large number of studies are excluded, and the strength of the study selected depends on the study selected in the systematic reviews itself, which is not ideal. So in addition, we also would like to look at a funnel plot. Ideally, they should be showing funnel plots for all outcomes which are there. So all the outcomes all the comparisons will still be, but they have not mentioned any funnel plot. So can any of the registrars, for the benefit of the clerks, tell us what a funnel plot is? What do we use the funnel plot for?
Publication bias.
Yeah, so we try to see if there is any publication bias for the funnel plot. what we see is we compare the study estimate on the x-axis, the magnitude of the effect, and we look, and on the y-axis we have the study precision. And when we plot like a scatter plot, we put the different trials. So for an adequate funnel plot, we need at least 10 trials, and usually these lines show the 95% confidence intervals. Usually there will be the scattering will be even on both sides, and it will be in the shape of an inverted funnel. On both sides it will be there. So if that is the case, then we say that there is almost all trials were included. There is no biased selection of trials. If all the trials included, then there is one. Suppose here this area is black. Then in that case, we will assume that okay, there is a significant number of trials which is not been included, which were probably not published, hence there is a possibility of a publication bias.
Yes, one more thing. Given that in a network meta-analysis, how do we look at a funnel plot is that for each and every comparison, there will be lot of studies. And for each and every comparison, there may be direct studies, there may be indirect studies. So, other than looking at how many are favoring on either side and how many large and small studies are, we will also be looking at how many direct and what is the distribution of direct studies and indirect studies also. That will also be another thing that we will look specifically in a network meta-analysis.
So this is the Prisma flow diagram for the study. So we can see that out of almost 13,000, 14,000 studies, they've screened and taken out 9,400 studies, out of which, based on the abstracts, 701 were eligible, 571 were excluded, and they've mentioned the reasons for excluded. In the supplementary article, they've actually mentioned each trial and they've mentioned why it was excluded. So totally the studies included were 84. So the next question is, did the meta-analysis address possible explanation of between study differences and results? So usually there will be, when you look at different studies, there may be different studies will have different results, and they can do subgroup analysis and meta regressions to explain that why the changes are different. However, in this study, they've actually shown that there was no statistical heterogeneity, and based on that, and there was no statistical incoherence. That's what they got. Also, this question becomes important when there are multiple control interventions. Then, even though the network analysis becomes better, we need to account for the differences between the control interventions and make adjustments accordingly.
Meta-regression is nothing but a statistical technique looking at heterogeneity in a network meta-analysis. So in a usual meta-analysis, we look at the individual studies whether they are showing very, very different results. Here we look at it in another way, whether direct and indirect are showing similar results or varied results. They are very varied, then it's more heterogeneous. If they are reasonably acceptable limits, then we say it's less heterogeneous. But the other terminology that's used is coherence and incoherence.
So the next question is, did the authors rate the confidence in the effect estimates for each paired comparison? So the confidence estimates, they usually they have used the great certainty of evidence tool. So this based on this, you grade different studies, different comparisons. They have graded into these categories. Usually it is high, moderate, low, and very low. Here they have put it as insufficient, and these are the different categories. It is usually based on the risk of bias, imprecision, indirectness, inconsistency, and publication bias. Any of this is there, then you'll get a lower grade. So they've done estimates. We see here for the direct estimate, DPP4 with GLP-1 agonist, which is our main outcome. They've actually done a certainty of evidence grading has been done according to the great certainty of evidence tool. So which has been done adequately for all the trials, all the comparisons they've actually done. There are large tables in the supplementary article. So summarizing.
Yeah, you see that the first column is the direct estimate, which is the direct comparison, and for that they have looked at the certainty of evidence. And the next estimate is the indirect one, meaning it's not the direct comparison, it's the indirect comparison now. And what is the estimate? So here it is 1.64, confidence interval of 1.04 to 2.59. Here it is 1.14 between 1.04 to 1.25. So just by visual looking at it, do you think both those results are grossly different, or do you think they are reasonably similar?
So that's a pooled estimate for all the studies which have compared DPP4 and DPP1.
This is the network estimate, which is the pooled one. This is direct, this is indirect, this is the pooled network one. If you think both are pretty much similar to each other, then it's fine. If you think that both are grossly different, then you will say that they are incoherent, in which case you will see that this heterogeneity will be much higher and there will be a significant incoherence, meaning p-value will be less than 0.05 or less than 0.1. In which case I square will be high or a p-value of less, then that will indicate that there is a significant incoherence. And even for the network meta-analysis, there is a different certainty of evidence. This one is only based on direct. So even for indirect also, you will look at certainty of evidence based on the parameters.
So summarizing our evaluation of the risk of bias for this study, we can see that the study mainly had main problems with the study were there was multiple doses and drugs of the same class which were used, which may adversely affect the risk of bias. Other language studies were excluded, which can also cause a bias selection. But otherwise, the explanation, there were not many study differences in the trials in between the results, and they rated the confidence in effect estimates for all the paired comparisons. Okay, now going into the results. So the results, there are 5 main questions we are going to be answering. We'll go through it one by one. So the first question is what was the amount of evidence in the treatment network? So this is looking at the number of trials which are there and the number of arms, number of patients, and we'll be looking at the actual results, the difference which was found. So the study has shown different, compared with placebo with different agents for all-cause mortality, major adverse cardiovascular events, MI, stroke, hospitalizations for CHF, CKD, and adverse events. So our specific question was about DPP4 versus GLP-1. So we look at that one in particular. So we see this K is the number of studies. There are four studies which are included. Total number of patients were 4816. The risk ratio was 1.64 with the confidence interval between 1.05 to 2.56. So that they've put in terms of patient number of patients also. They've not put the denominator, but usually they put in the denominator 1000. So the mortality in DPP4 range was, according to this study, it was 7 more deaths, but it can range from 1 more death to 14 more deaths in 1000 population. So that is our estimate. So here they've again put the grade they have put, and that is moderate. And this symbol in the footnotes of this table, they've mentioned that they've given a lower grade because of the risk of bias. So that is our study. So like this, you can interpret each of those values which are there. And here, whenever it was not done in the network analysis, they've mentioned that it's not in the network analysis. So were the results similar from study to study? So from the previous picture, we know that there were 4 studies. Here the table is the other way around. GLP-1 is on the left, DPP4 is on the right. So we can see that it is comparable. The results from each studies are comparable. All the point estimates are on the same side of one, and they only vary by the confidence intervals. So we can say that it was comparable. Were the results consistent in direct and indirect comparisons? So in the supplementary article, they have mentioned there are these tables for the network meta-analysis, and for all-cause mortality, for our specific question, we can see that they've put a direct estimate, they've put an indirect estimate, they've put a network estimate also, along with their and the incoherence levels, everything they've documented. the results we can see that the direct and indirect are comparable, especially when we look at the confidence intervals, it is somewhat comparable. Indirect estimate had a smaller confidence interval. Other than that, it is comparable, and network estimate also is comparable. So how does the treatment rank and how confident are we in the ranking? So ideally what they could have done was, they could have, for each outcome, they could have ranked all the drug groups. So first is SGLT2, second is DPP4, they could have done like that. But they have not done that. Instead they have done summarized comparisons for statistically significant results. So for the all-cause mortality, they have mentioned that SGLT2 is better than the other modalities. Then GLP-1 is probably better than insulin and DPP4 inhibitors. Others were not statistically significant. That's how they put the ranking. Were the results robust to sensitivity assumptions and potential biases? So ideally, what this question implies is, usually for network meta-analysis, we will do sensitivity analysis assuming that the high risk of bias studies were removed. And if the study is still similar, if the results are still similar, then we would say that the results are robust. Here they have assessed the risk of bias. They have not said anything about excluding, but most of the studies are low risk of bias. So they've assessed using the Cochrane risk of bias tool in the 5 domains they've assessed. So going into the last set of questions, how can I apply the results to patient care? Were all patient important outcomes considered? If you remember the results study, they have looked at a lot of outcomes: major cardiovascular events, heart failure, stroke, renal failure, and adverse events also they've looked at, which is good. From a personal point of view, I would prefer to say quality of life outcome also, and probably peripheral neuropathy, which is one of the common things which our patients come with, which could have been considered. Were all potential treatment options considered? Yes, all the recent drugs have been considered. Are any postulated subgroup effects credible? So here in this trial, subgroup effects done were limited, and only a description was done. They've not commented much about the subgroup effects. So coming back to our clinical scenario of the 40-year-old man, so we will, whether he's on teneligliptin, should we stop teneligliptin and start GLP-1 agonist for the mortality benefit? So again, here we see that the confidence intervals are from 1.05 to 2.56. So even though they say there is 7 more, based on this study, there is 7 more deaths which can happen if you are on DPP4 inhibitors. The confidence interval is between 1 more death in 1000 to 14 more deaths in 1000. So, which is almost the same, we can say. So there is the certainty of evidence also is moderate because of risk of bias. And comparing the cost of liraglutide per month comes to around 3,600. Cost of teneligliptin per month will come to around 450 rupees. So based on all of this, personally I would say I would not change the drug, but everyone's interpretation can differ. And if we have now for the GLP-1 agonists, Indian companies are also getting licensed, so the cost may come down, in which case they may become a more viable option.
Any questions?
The indirect comparison, they actually use the exact figures of the results. For example, if they are comparing one GLP-1 agonist with the DPP4 inhibitor, there is one study comparing metformin with both of these drugs. Then do they use the actual numbers and then compare?
There is one with metformin versus these two.
These two studies.
Yes.
If we want to compare GLP with
DPP4, this will be the direct evidence, and based on these two studies, they use the same data to identify what will be the assumed benefit between these two comparisons. That also will take as indirect comparison.
But still the number of patients might be different, the dosage, everything might be different, but still an indirect comparison they can have.
Yes, they may have chosen different dosage of metformin glimepiride here, whereas different dosage here and here. That is a possibility. So all these only will amount to the transitivity. any change in population characteristics. Suppose in this study the mean age was 65, in this study the mean age was 40. That will also affect the incoherence, transitivity. Or here high dose was used, here low dose was used. That will affect. So any population intervention control characteristics change will amount to transitivity. That's why we compare both the results. One is we first compare the Picot statement. If you think that the find changes are acceptable, then you calculate the indirect estimate and pool the results. If you think that by itself the transitivity is not satisfied, then you don't do the indirect comparison at all. You just stop there saying that there is too much of intransitivity. I am not going to do indirect comparison based on using this data. The other option is if you find such a study, but if you find studies which are showing comparable arms, suppose there are another two studies which have shown similar population characteristics. In that case, you can do a sensitivity analysis. I'll exclude these two studies which have high intransitivity, see what the result is. I'll include these and see what the indirect result is. If it's grossly going to change, then that means that that is what is that sensitivity analysis. So if you do this, what is the final result? If you don't do this, what is the final result? Is it changing too much? So if it does not change, in spite of doing all these sensitivity analysis, then your result is robust. Okay, even if there are some variation, looks like this drug will continue to work. So that is how we interpret. Suppose sensitivity analysis also shows better mortality benefit with GLP. And suppose there was no risk of bias also, then even for that one death per 1,000, you may probably want to start. But given that the certainty of evidence is also low, risk of bias was the reason why they had downgraded a high quality evidence to a moderate quality. And that the estimate was very close to 1.06 was the point, the lowest of 95% confidence interval. It is possible that there may be no difference in mortality, but there may be some mortality benefit. For that, would you be willing to invest that additional cost? In fact, they had not provided the denominator as rightfully Thomas pointed out. So they had not given that. If we say 7 more, out of what? That is the important information that we should know. Rather than just giving 7 more, it can be 1 more or 15. There should have been a denominator that they should have given. That would have made a calculation easy. We could have easily calculated the number needed to read. Okay, we'll give the clerks some homework. Suppose 1 more death, which is the difference out of 1,000. 1 extra death per 1,000. Say I'll give you an example. In DPP4 arm, there are 50 deaths per 1,000. In GLP1 arm, there are 51 deaths per 1,000. Oh, yeah, okay, sorry. 49 deaths per 1,000. Which is better? GLP1 is better. How many deaths does it save? 1 per 1,000. So what is the absolute risk reduction? 1 per 1,000 is, what is the percentage? 0.1 percentage. That is the absolute risk reduction. What is number needed to treat? 10. 1 by 0.1 is 10. 1,000. Usually 1,000. So if you treat 1,000 patients, you will be able to save 1 death. If you treat 1,000 patients with GLP1. So what is the cost of GLP1? You just okay. So cost of liraglutide per month, and the average follow-up was 52 weeks. No? So you have to give this for 12 months, and you have to treat 1,000 patients. What is this? 3,600 per month. You treat them for 12 months, and you treat 1,000 such patients. $43 lakhs, okay. if you invest 43 lakhs, you can prevent one death from diabetes in 1 year. You are happy with the drug? No. Don't think one life is worth 43 lakhs. You won't spend 43 lakhs to save one life. Huh? No. Nobody thinks one life is worth 43 lakhs. Okay, that's your decision. And is it a tablet, injection? It is a pre-filled syringe, or you have to draw it like an insulin and you have to put it. Sorry, suppose if it's an insulin syringe, then you have to add insulin syringe cost for 1 year. Maybe because of putting it, they may develop a hematoma or some injection safety infection or abscess. If that happens, you have to add to the complications of this and add to the cost. So all these are there. We have looked only at mortality benefit. We should also be looking at arms of liraglutide and see what is the cost of that, and we should include that also. So this is only a rough calculation based on the mortality benefit alone. So finally, looking at this meta-analysis, will you say it is a strong recommendation to give liraglutide to all patients? Or will you say it is a conditional recommendation? If you want, give it to some of them. If you don't want, don't give it to some of them. Loves. How many of you will say, I strongly recommend GLP-1 analog over DPP-4 inhibitors? How many will say it is a conditional recommendation? Okay, so that is what. Yeah, I mean, what is the difference between strong recommendation and conditional recommendation is that suppose if it is a strong recommendation and if you don't prescribe someone with GLP-1 analog, then it will be considered a crime. For someone with MI, if you don't give aspirin, it's a crime, literally a crime. You can be taken to court. But if you say that I have not done PCI because of so and so reason, it's not that it's a huge crime. Okay, you are giving the next best treatment. So that's how it is. If it's a conditional recommendation, it may save some additional life, but if it's a strong recommendation, then it definitely saves additional lives. There is no second way or second thought about it.
Can we apply the same as for side effects and harms?
Yeah, we can use the same network analysis for side effects.
So whatever data was there, we can extrapolate it to harms. Another thing was about publication bias. We say usually they might not publish results which are poor. In case all publications were showing a good effect, we still consider it. We don't know, we will never know that it was whether studies which were not
Yes,
included.
so if at all the funnel plot shows one vacant area, then that's what we said in a randomized control trial. Following evidence from a randomized control trial, the thing is, we start off with 4 pluses. This is the high quality of evidence. And we usually downgrade based on indirectness, imprecision. Third is heterogeneity. Fourth is risk of bias, and fifth is publication bias. So these are the 5. Suppose if there is directness, there is good precision, there is heterogeneity alone, it's there, significant heterogeneity, then you erase off 1 plus. And then if there is no risk of bias, leave it. If there is publication bias, then remove 1 more plus. So what was a high quality evidence now has become a low quality evidence. But if there was only publication bias, it will be a moderate quality of evidence because you would have erased only 1 plus for publication bias alone. So you will say it's not a high quality evidence, but it's a moderate quality evidence. Based on that, you have to decide whether you are going to recommend it strongly or not.
So like in an ideal setting, if all the studies are included and everything is showing one side, favorable, and other side is actually empty, then you still say that
it's not favorable or not favorable. Just that the funnel plot, this is the final result estimate. Suppose the final result is say 2. This will be 1.5, this will be 2.5. But whereas one is here only, this is the line of no result. Some results should show the other side of the final result. Some studies should show other
It's
this
already
side.
not null points.
It's not a null point.
It's not an estimate.
Null point can be somewhere else. But the final pooled estimate, on either side of the final pooled estimate, you should have equal number of small and large studies.